to quiet it down doesn't slow them up and they charge me more. But today I'm going to talk to you all about hopefully the fact that you all can be ambassadors with this, with the conversations we're having. And I'm going to also, I think it would be remiss if I didn't tie in some tragic events that are happening around our country, around our nation, against our Asian American community. And because we have to understand that when hate can happen against one of us, hate can happen against any of us. So this conversation around COVID-19 and health disparities and health inequity has to be a conversation around equity. So without further ado, I will share my screen. Just let me see how I can get to the slideshow. Can y'all see that okay? I know it's not in presenter mode yet.
Yes, we can see it.
Okay, let me now put it in. All right, sorry about that. All right, so today I'm going to talk to you about myths and facts about COVID-19 vaccine, a community conversation. But today's community conversation is one with the youth. And I really believe that you all have the greatest opportunity to really help us change the narrative on some of what we're seeing right now. I've shown this map before, and it can actually be updated. So once we come off of mute, I'm going to actually, once we get into the discussion section, I'm going to actually ask you all to kind of join in the discussion about this. By a show of hands, how many of you all have ever heard of heat maps or seen maps like these before? Just going to scan the room real quick. If you can come off of mute, I understand that some of you might not be able to, I mean, not come off mute, but show your screen. Yeah, so a few of you have heard of these things called a heat map before. Well, heat maps are something that we use in epidemiology. And epidemiology is the study of data, basically, and how data and statistics tell us about disease and where diseases are happening. So all the conversations that you've heard about where and who is impacted by COVID-19 has been driven by epidemiological data. Epidemiologists are people that are trained in public health. They usually get a master's of science or a PhD or some other doctoral degree and to study data and how it impacts communities. If you all have had the chance to meet one of the founders and directors of Chicago Check, Dr. Melissa Simon, she's actually an epidemiologist that's actually an epidemiologist and a clinician. So you can be both. You can be both a clinician, an MD, and an MPH, someone who can study data as well. And so if and when you have the chance to talk to Dr. Simon, make sure you talk to her about her role as an epidemiologist, because it's something that not a lot of people know about her, but it's another one of her areas of expertise. So in these heat maps, what do you all notice about these heat maps? So the one on the left is about mortality rates related to COVID-19. And so that legend that you see tells us mortality rates per 100,000 people. So the darker the blue area, the more people have died from COVID-19 in those community areas. This map is a map of the 77 community areas in Chicago. I would encourage you to look at the map right now and see if you see your zip code. So for example, I live in 60615, so I live around this area over here. But look at what's happening in 60649. That's a community area called South Shore. In South Shore, more than 219 to 312 people per 100,000 people have died. And this is from January 2020, you all, have died from COVID-19. But then look at what's happening where testing is taking place. This is the people who are dying. So look at all these communities. Look at 60629, 60621, 60636, 60621, and 60636. These are community areas in Inglewood. Right now, there's efforts that happen in these community areas to try to increase the COVID-19 vaccine that's happening. Even today, over the past 2 weeks, our Miles Square Inglewood Clinic has vaccinated over 3,000 people for COVID-19 in these Southside zip codes. And we've started to vaccine community members in the Back of the Yards neighborhood, started last week as well. So we're really moving forward, making sure that Black and brown communities that are underserved are getting vaccinated. But we still have access issues with testing. So if more people are dying in 60649 and these other zip codes like 60636, 60621, West Side neighborhoods over here, why is there less testing in these areas? Why is there less testing in 60649 compared to the death rates in 60649? Why is there less death rates in the Gold Coast, right over here in these zip codes downtown, 60607, 60601? These are all downtown Gold Coast zip codes. Look at what's the testing, all dark blue. That means that more people are being tested in these areas, despite the fact that less people are dying in these areas. More people are dying in these areas and less people are being tested in these areas. So when you all signed up and registered for this event, you had to, I think there's a question about whether or not you have heard of the term health equity. If you had or had not, this is an example of a lack of health equity. This is the total opposite of what health equity is. So how did we get here? How did this conversation begin? Because I don't want you all to think that the vaccine hesitancy that you see in many of your great grandparents and many of your grandparents and your parents, even in some of your friends, you don't want to assume that the hesitancy that they have is just because they don't want to comply with someone who said that they should get the vaccine. This hesitancy is rooted in a lot of historical misgivings that have happened to Black and Brown communities. Many of these misgivings that have happened still have a vivid footprint in our society today. For example, in 1932 to 1972, the National Public Health Syphilis Study at Tuskegee, Alabama happened. That's where thousands of Black men who knowingly had syphilis, where treatment was withheld from them, from treating them for syphilis, all because they wanted to study the natural progression of syphilis in Black men in the South. The last survivor of one of the men from this study, his wife is still living, and his granddaughter is now a health advocate. And despite the treatment of many of the 1,000 men like this woman's father or grandfather, she still comes out and says, despite what they did to us in the past, let's make sure that we own the narrative today and that we're a part of the solution. And we do not let what they did to us in the past impact what we take advantage of today. Another thing that happened, as many of you may have read about, in 1951 was Henrietta Lacks Sales, an African-American woman from a tobacco farm, was her cells from her cervix were unknowingly taken from her because she died from cervical cancer. We now know that cervical cancer is related to HPV, but we didn't know that back then. All we knew was that there was an unfortunate incident that had happened with this Black woman who had cervical cancer in her late 30s, early 40s, and she died, leaving several children to be without a mother. And those cells went on to be used in several scientific experiments. Now, although those cells have been used to save lives, how those cells were acquired is where the historical mistrust happens. Even in 1990, in 2010, additional unconsented subjects in Guatemala were discovered in reviewing the Tuskegee syphilis study. So this happened in 2010. We learned out about unethical experiments that happened in Guatemala. The list goes on and on. But what came out of these historical unethical events was the fact that we now in the US have things called the Institutional Review Board. We have the IRB, we have the National Commission and the Belmont Report. These are all things that ensure the ethical conduct of research. So these things actually came out as a result of the unethical things that have happened. So first take home point. When your family members ask you and they say, you know what, I don't want to participate in research because of things that happened in the past, they may mention the Guatemala studies, they may mention the study with Henrietta Lacks, they may mention the United States Public Health Service study that happened at Tuskegee, Alabama. They may mention those things. What I want you to say as a scientific advocate is to say, you know what, you're right. Those things did happen and they were jacked up. That was wrong. But since then, there have been things that have been put in place to ensure that events like that no longer happen. There's things like the Institutional Review Board. There's things like community members that sit on that Institutional Review Board. So before you do any research, this is even true for the COVID-19 vaccine. Anyone who participated in the COVID-19 vaccine had to go through an ethical review process to make sure that study, that the benefit outweighed the risk. So this whole concept of warp speed, I hated that term. When they start calling the project Operation Warp Speed to talk about a vaccine, personally, I don't want anything that was developed at warp speed, not even my food really. You know, I even think about the fact that if it cooks too quickly, it's probably not that good for you. You know what I mean? I know we live in a society where everything is fast paced. I know some of you are like, oh no, Dr. Watson just coming down on microwaves. I kind of am a little bit, because it's nothing like the slow cooking of that rice, or slow cooking some beans, or slow cooking a good old pot of greens with some smoked turkey. It's nothing like it. And if you do it too quickly, it don't got the same effect. I'm sorry. So what happens when what happens when you've been mistreated and no one is really saying that you've been mistreated? Sometimes you can stunt the voice of people. And when people don't feel heard, they often will say, you know what, if you're not listening to me, I can show you better than I can tell you, right? And so when people start showing you better than they can tell you, that oftentimes looks like civil unrest. I'm not justifying it, but I'm saying I understand. I understand what happens when your voice has been muted and you feel like you don't have a platform to talk about what's going on against you. Well, we actually had a platform with the family of Henrietta Lacks. And just this past weekend, I was in communication with the great granddaughter of Henrietta Lacks, Veronica Robinson. Veronica and I are working together on some projects to talk about how can we get more young people like you all involved in careers in health disparity, in careers in research, in careers in precision medicine, so that more of you look like the people that are asking the questions and doing the research and participating in the research, because representation matters. And it's as simple as that. So what is structural violence? You all have heard about health and equity, but I want to introduce to you all a term today called structural violence. So structural violence is a term that describes the multiple characteristics of social, economic, and political systems that expose vulnerable communities to physical, socioeconomic, behavior, or psychosocial risk, leading to increased morbidity and mortality. All right, what does that mean? It's people, places, and things that prevent people from being healthy. I'm going to repeat that. It's people, places, and things that prevent people from being healthy. So if you have a population, if you have a healthcare system, and that healthcare system says that you have to have a social security number in order to receive care, that's structural violence towards anyone that may not have a social security number. Because you may not have a social security number because you may be fleeing your home country for political asylum. You may be fleeing your home country because of violence that may be happening against women. You may be fleeing your home country because of opportunities that just were not available there, because through colonialism, your home country may have been robbed of its resources and robbed of its ability to be really, truly be the amazing country that it is. So, but right now, there are still some people, some citizens in the US, because they don't have a social security number, they can't get healthcare screening as accessible as others. So imagine, would that person want to sign up for the COVID-19 vaccine? If that person has not had access to the healthcare system, would that same person want to come and get tested for COVID-19? If there's been incidents where that person has been racially targeted by a healthcare system, when they go to check into that healthcare system, because they were 5 minutes late, because they work an hourly wage job, and because they had to drop their granddaughter off at daycare because they're helping their daughter out. And when they get to that desk to check in for that visit, the front desk person tells them, oh, you're 10 minutes late, we can't see you today. So when these are real life things that happen, or someone who needs a mammography for breast cancer screening, and because of the color of their skin, because they may be African-American and uninsured, they get different treatment. These are not things that I'm telling you all in hyperbole. These are things that actually have happened to people. So structural violence is anything that can impact someone's health outcome. So what does it look like in healthcare? It can be social policies, like I said, let's take breast cancer screening, for example. So let's just say, in order to get proper breast cancer screening, to get a mammogram, that's one of the ways you screen for breast cancer, that a woman has to have insurance. Well, if she has to have insurance, or she doesn't have insurance, because of where she lived, that neighborhood context, she may not have access to a state-of-the-art imaging machine, right? A state-of-the-art mammogram machine. So she just went to wherever she could go to get that mammogram done. And unfortunately, where she went to get that mammogram done, that hospital may not have all the best resources. As a result, she may get a diagnosis of breast cancer that may differ from someone who went to Northwestern or UIC or one of our academic medical centers to get that same screening. And then that leads to a health inequity. Her journey through her breast cancer treatment starts off bad and can end up as a health inequity. I have a real life example for this. This is a 60-year-old African-American woman who was uninsured, who went to a community hospital in 2015 to get a mammogram. She went to that community hospital because that community hospital was offering free mammograms. Once she got that mammogram, but before she went to the mammogram, let me tell you what happened 2 visits prior. 2 visits prior to that, this woman went to the emergency department because she had a lump in her breast. She complained about the lump in the breast, and the emergency department asked her, have you ever had a mammogram before? She said yes. They said, was it abnormal? She said, no, it was actually normal. They said, okay, this is probably some type of infection or something else. They sent her home. She comes back to that emergency department and says, I need to really get this checked out. So lo and behold, she gets it checked out. She ends up getting a mammogram at that community hospital. They find out that they tell her that she has breast cancer. And they tell her, after they tell her that she has breast cancer, she meets with a surgeon, and that surgeon tells her that she needs a mastectomy, meaning that they need to remove the entire breast where the cancer is located. They didn't tell her what type of breast cancer she had. They didn't talk to her about whether mastectomy was the best option. They didn't tell her what type of chemotherapy she would get. They didn't tell her if she qualified for radiation therapy. All they saw was an older Black woman who was uninsured. I am not saying that that doctor unethically set out to do her wrong, but structural violence had all these systems in place that led to her getting referred for that treatment. Lo and behold, though, there was a community navigator at that hospital. That navigator works for one of my favorite organizations called Equal Hope. Equal Hope used to be called the Metropolitan Chicago Breast Cancer Task Force. Well, there was a navigator at this community hospital that heard this woman's story. And might I tell you, this navigator was not a doctor, not a nurse. This navigator was a regular community member, just like many people that we know. But that navigator stepped in and said, something doesn't feel right about this story. So that navigator got this woman screening, another appointment with another doctor at an academic medical center. One of the big hospitals, like a Rush, like UIC, like Northwestern, like Loyola, we all have the designation of being called academic medical centers. So once they got her to the academic medical center, the navigator did this. Not some fancy doctor, not some nurse, a navigator. Got her to that new academic medical center. They told her, wait a second. The type of breast cancer that you have, you don't need a mastectomy. You actually just need what's called a lumpectomy. We can actually just remove the tumor without removing your entire breast. But what if that woman who was uninsured had never ran into that navigator and she went on to have her entire breast removed for a cancer that she thought would possibly end her life? That's an example of structural violence and health inequity. Now, fast forward to the health system coming to this same woman saying, will you sign up for the COVID-19 vaccine? She's probably gonna look at them side eye and be like, no, I'm not signing up for the COVID-19 vaccine. The healthcare system has not loved on me, so why should I love the healthcare system back? We gotta stop believing and assuming that Black and brown people are gonna suddenly love on the system that ain't loved them back. And we got to begin to acknowledge the fact that the system has not always been good to us. And as a result, the system has not always been good to us. We're not always going to say yes. And we're definitely not going to say yes when the people asking us don't understand our lived experiences. So we got to have more real conversations about what I call the real, about why people are saying no. But then also systemic racism has showed up, like I said before. I remember the day when I heard some elected officials call it the Chinese virus. I remember hearing that and cringing because I knew that that labeling would result in some members of our community getting unjustly targeted. This is a quote from an activist, Asian American activist, who said, I have seen this incredible seesaw effect. We can go back to the turn of the century when Chinese were the only people to be legally excluded from this country because people were so fearful of the jobs they were taking. Doesn't that sound familiar to often the narrative we hear today? That was seemingly a place that we would never go to anymore. That level of vitriol, we've seen it though, in waves since World War II. We had an Asian enemy, Korean War. We had an Asian enemy, Vietnam War. We had an Asian enemy. And then we had Asian enemies that were economic in nature. This is from Janet Yang in a 2020 interview. And what she was talking about was this conversation around mislabeling the SARS-CoV-19 virus, the Chinese virus. That is such a dangerous term, you all, because nomenclature matters. What is nomenclature? Nomenclature is the naming of something. And so this poster there that says, "I am not a virus," is such a powerful statement. This statement that says, "Fight the virus, not the people," is so important because the events that happened in Atlanta this past week in that spa, make no misconception about it. That, you all, is a hate crime. That is targeting people because of the color of their skin and their nationality. That is xenophobia, and that is a hate crime. It's no different than what we saw after 9/11 when they were unjustly targeting people that were Islam and Muslim backgrounds. It's no different. That is a hate crime. And what I want you all to know is that how all of these things can fuel whether or not people are actively taken up in the healthcare system. Because now what has happened is that people in our Asian American community, many of them, especially the older community members, are afraid. So if they're afraid to come out, they're afraid to come to public events, why would I come out and get vaccinated? So this is going to impact vaccine uptake in this community area, which is going to lead to a health inequity. So like I said before, nomenclature matters. Let's talk about the concept of hesitancy versus access. Believe it or not, there's not as the vaccine hesitancy, it's real, but there's more issues of access than there are issues of hesitancy. I talked to way more. One of my colleagues emailed me from Little Village, and she was like, "Karriem, when they did that COVID-19 vaccine outreach in Little Village," she said, "Karriem, I don't have a problem identifying Latina and Hispanic people that want to get the vaccine. I actually have a wait list. The issue wasn't that there was Hispanic and Latinos that didn't want the vaccine. The issue was access. They didn't know where they could get it or when they could get it. But when it was made available to them, they got it." That's the same thing we're seeing on the south side of Chicago and Inglewood right now. And then this is controversial, but I'm going to put it out there. This conversation of not understanding the term all lives matters versus Black Lives Matter. Saying Black Lives Matter is not saying that all lives do not matter. Saying Black Lives Matter is simply saying that because of the color of your skin, you can unjustly get pulled over by the police. I was walking my dog the other day on the south side neighborhood in Kenwood, and the police pulled over and they pulled up to the corner and rolled their window down. For a second, I thought to myself, all right, Karriem, you have your ID on you. I had on a hoodie. I normally don't wear a hoodie, but this particular day, I took the day off yesterday because I have to work all day today. So I had on a hoodie. Even though it was my fraternity hoodie, it still was a hoodie, and you couldn't see my fraternity on my chest. So all I knew that this cop pulled me over. I got this big old black dog. I'm a big old black man. I got on a black hoodie. I was like, ooh, do I got on my Gucci tennis shoes, or which tennis shoes do I have on today? I was like, maybe my Gucci tennis shoes gonna save my life today. I was like, oh man, I got on my Nikes. I was like, I just looked, and all this is going through my head. She rolled the window down and said, hey, be careful out here. It's a lot of carjacking going on. The Uber driver just got carjacked. And I'm thinking, I took a deep breath and I said, thank you so much. I'm being extra careful. But should you have to go through that? Because the police pulls up to a corner, should you have to think about what you have on? Do you have your ID? Granted, I pay taxes in this area. So technically I pay that police officer's salary. But because Black lives have not always mattered, because of the color of your skin, I could easily be a George Floyd. I don't want you all to think that because I'm Dr. Watson, that means that my life and my breath matters. That is not the case to everybody. if you're just because an African-American woman is a physician, when she's driving her car or when she's in her apartment, her name may as well be Breonna Taylor, because no one sees her MD, no one sees her credentials when they pull up to that apartment and unjustly enter that apartment. So make no mistake about it. We still live in a country, we still live in a time when, because of the color of your skin, you can be unjustly targeted. And having the videos doesn't mean that that the people who did the crime are gonna get off. And I said before, the China virus versus COVID-19, what we say has consequences. So when you hear people misappropriately say the China virus, cut them off. Say, you know what, I gotta stop you right there. That actually is dangerous towards Asian American people. Please call it the SARS-CoV-19 virus, because by making that statement, you're putting a group of people, you're making them the target. So the other thing that matters is this whole concept of vaccine hesitancy. It didn't just come up with the COVID-19 vaccine. We've been hearing about vaccine hesitancy a lot, especially because I said what you say has consequences. There have been a lot of stars that have come out with information that's actually not based in fact. I love Jenny McCarthy, but she's come out against vaccines because she's talked about some information that vaccines are linked to autism. That actually is not true. That's actually not grounded in evidence-based research. And so we need to make sure that the conversations that we're having about vaccines are rooted in evidence. So if, for example, HPV is the vaccine HPV is the virus that causes cervical cancer. There's some countries where they're really promoting the HPV vaccine because they know that they have higher death rates for women in their country as a result of the HPV virus and cervical cancer. I've been fortunate enough to be able to do work in rural Haiti, Ethiopia, and Uganda. When I go to those countries, I see the devastation that cervical cancer has had on those women in that country. Cervical cancer should not be killing women because there is screening for it. And if you screen for cervical cancer appropriately, you can actually remove the cells that could potentially go on to become cancerous cells. There's also a vaccine for cervical cancer called the HPV vaccine. But because we don't always have conversations that are rooted in fact, we misappropriately talk about vaccine hesitancy and vaccine being associated with things that there's no scientific evidence for them being associated with. Even the fact of this measles outbreak that happened in 2015, because of because of some of the conversations that are taking place, some parents right now are choosing not to vaccinate their children. And I don't judge them, but I do say, please have a conversation with your pediatrician about making sure this conversation is grounded in facts, because as a result of the fact that some people are no longer getting vaccinated at their normal vaccine schedule, there was an outbreak of measles in 2015 that was traced back to Disneyland through an epidemiologist. That just happened in 2015, you all. That happened in your lifetime, right? So we really have to be careful about grounding our conversations in facts. So this is the daughter and the granddaughter of the family member of the Tuskegee syphilis study participant. She said, there's a desire, I'm going to read the quote from her. She said, there is a desire and a need for us through our foundation and through my professional work to want to move the story of the syphilis study to one that speaks towards being a victim to being a victor, from moving from trauma to triumph, says Dr. Thornton, who works as Director of Research, Grants, Workforce, and Development at the National Academy of Child and Adolescent Psychiatry. She is the granddaughter of someone who participated in the study. So we're starting to change the narrative. But I also want to leave you all with this, and now I know I'm about 10 minutes before we open it up for questions. So one of the things that people have talked about is the fact that, oh, I'm not taking the vaccine because it was developed too quickly. I don't know who was in it. I don't know what the study looked like. Was there even a study? Who participated in the study? Did those in the study look like me? The answer is yes. So I'll talk about the Pfizer vaccine, then I'll talk about the Moderna vaccine. So the Moderna, and all this information you all is public. I don't have access to some special data because I'm a scientist. You all have access to this data too. You can Google it and go to fda.gov and do results from Moderna, Pfizer, or even Johnson & Johnson. So there were 49.4% women that were involved in the Pfizer study. 81.9% of participants were white. That is still a high number, but usually we only have about 10%, less than 10% underrepresented minorities that participate in clinical trials. But through aggressive efforts, we actually had 9.8% African Americans participating, 4.4% Asian Americans, and then we had another 26.2% participants identified as Hispanic or Latino. That is really good efforts to make sure that this study was diversified. 21.4% were older than 65, and the median age was 51. And then the population also had conditions that reflect those of America. 35.1% of the populations were obese, 8.4% had diabetes, 7.8% had pulmonary disease. And there's also this myth out there that said that, oh, people that were in this study weren't from the US. That is not true. 76.7% of the participants were from the US. And then the same is true for the Moderna study. The other thing that was out there is that this study was, I don't know about you all, but I've heard a lot of things. I've heard people say that this vaccine was developed to insert the COVID-19 virus into Black and brown communities, that I've heard that it was, if you insert this virus, you'll end up getting the COVID-19 virus. None of that is true, you all. And so how were they able to do these studies so quickly? This is not the first time. We actually have a procedure in place through the FDA, the Food and Drug Administration, called emergency use authorization. I believe that one day, some of you all are going to have to use an emergency use authorization, because you're going to be brilliant scientists. And you're going to develop something one day that says, you know what? I've just developed a drug that I've been working on since I got my PhD when I was a fellow through this program called Chicago Check. I've now developed this vaccine that can cure breast cancer. And so I know that I want to get an emergency use authorization of this vaccine so that I can begin to utilize it in populations that are heavily impacted. And so you may apply for an EUA, an emergency use authorization. That emergency use authorization is what allows us to get the vaccine out in a sooner time period than what it normally takes for drugs or devices or treatments to go from research to the community. That's what allowed us to get this out so quickly. Not bad science, not breaking the rules, but things that are in place called emergency use authorization. There were scientists out there like Dr. Kizzmeiki Corbett, who's an African-American woman who is leading the charge in helping to develop the Moderna vaccine, who helped to develop the science around the Moderna vaccine. Something else that you need to know is that the science for SARS-CoV-19 is not new. We've been looking at the coronaviruses are a set of viruses that have been out for decades. They've been studied for years. Now, SARS-CoV-2 is new, but the virus, the science for developing vaccines is not new. So we need to really disrupt this myth that it was developed too quickly and that I won't take it because it was developed too soon. Even the fact that there's studies out there that are monitoring people for long-term side effects to see what will happen. And so the last thing I'll do is just give you some quick science about the vaccine itself. So this is a picture of the coronavirus SARS-CoV-2. And this is a picture of the virus a lot of you all have seen. Those things on the tops are called spike protein. There's enveloped lipids, which is our fats, and then there's capsid proteins on the inside. So we have two things in our bodies that help us fight vaccines. We have antibodies and we have white blood cells. Antibodies is like your body's memory of saying, I've seen you before. Antibodies is that text you keep, that you want to keep that text when you broke up with someone and you think that, you know, I might think about getting back with them, or you used to be friends with someone, but they threw you shade, and you keep that text when they threw you some shade, and you go back and read that text sometimes because you may have the inkling to answer the phone when they call, or you block their number. You know, remember, you know, you block their number. I don't know if y'all still do that, but back in my day, we used to block numbers. And so that the person couldn't call you. So if it rang, it's unknown. And you're like, oh, that must be somebody I blocked. That's what the COVID-19 vaccine does to you. It lets you know who you should not answer. And it gives you the ability to recognize callers that you don't want, and it lets you block those callers. So when you get vaccinated with the COVID-19 vaccine, what's happening is that the vaccine warns the immune system to stop the COVID-19 virus from entering. The vaccine does not give you COVID-19. It actually gives you an ability to understand what COVID-19 looks like and it allows your body to develop a memory to what it looks like. And then once it enters, it recognizes it, and your immune system can work more effectively because it recognizes it. But without the vaccine or without antibodies against COVID-19, if that virus enters your body and you catch it, like many of the thousands of Americans that have died from it, your body doesn't have time to mount appropriate immune response because it's trying to both kill the virus, fight off the effects that the virus has caused, and to develop this memory to the virus. That's too much for your body to handle. So what vaccines do is they say, while you're healthy, before you have to fight the virus off, I'm going to give you a knowledge and a memory to be able to recognize this virus so that when it calls, you know not to answer. That's what the COVID-19 vaccine does. It does not give you coronavirus. It is not even a live vaccine. So I'll end with that to let us to kind of, so we can move into some question and answer period, because I want to hear about what you all have to say about some myths that you all have heard. To hope we can dispel some of those myths today. But I got a lot of more slides about the virus itself, but I wanted to save those just in case we get into some questions. Sorry, see, I had a lot to talk to y'all about today. All right.
Great. Thank you so much for talking to us. I think we all have like a lot of information to take home, so thank you so much. So one of the first submitted questions from the students is, why are the Latinos so scared about the vaccine?
Well, first of all, I want to say I'm not Latino or Hispanic, but one of the things is kind of what I said earlier before. I'm always careful not to answer for communities, but I'm going to pose a different question. When we say that Latinos or Hispanics are afraid of the vaccine, is that truly the best? Is that really the best framing of that? Or is there some justified hesitancy of things, right? That's the question I want to say. And I want to put that to you all. When you've talked, if you happen to have family members that may be Hispanic or Latino, and they've talked to you about some vaccine hesitancy, what have been some of the reasons that they've said? I want to pose that question back out to you. So feel free to come off of mute or put it in the chat. And Nana, I can't see the chat right now because I'm sharing my screen, so you got to help me with the chat.
Yeah, I can see this chat, so I'm gonna let you know if I come across any questions.
There is an interesting question, Dr. Karriem Watson. Why can younger people take the vaccines that have been created?
You said when?
No, why can younger people take the vaccines that have been created?
That's a great question. One of the reasons why younger people can't take the vaccine yet is because when the research study that took place to approve it, it approved it in those that were 16 and older for one of the vaccines and 18 and older for one of the other vaccines. It has not been approved yet in people that are younger than 16. And a lot of that has to do with the clinical trials. Remember, I talked to you about that EUA, that emergency use authorization. So there were some populations that weren't included in the clinical trials to test the vaccine. Children were not included, people younger than 18, and pregnant women were not included. Pregnant or lactating women were not included. And the reason that they weren't included is because before we include women and children in studies, we like to do it in adults first to see how it will work. And then we include women that are pregnant and children in those studies. But what right now, there are studies taking place to see how the vaccine, how effective it is in youth that are younger than 16. Does that answer your question?
So regarding the process of taking the vaccine, how long do you have to wait between your first dose and second dose of the vaccine?
It depends on which one you get. So there's 3 FDA approved vaccines out there. There's the Pfizer vaccine, and the Pfizer wait is 4 weeks or 28 days. The Moderna vaccine, the Pfizer vaccine is 28 days. Moderna is 3 weeks. And then the Johnson & Johnson is 1 shot. But if you've been, there's another concern, someone says, well, what if I've been impacted, but what if I've already had the COVID-19 virus already? What if I've tested positive? Do I still need to get the vaccine? The answer is yes. but you need to talk to your doctor, because most doctors say that you need to wait about 90 days, which is 3 months between the time you tested positive for COVID-19 and getting the vaccine. But talk to your doctor about that time period.
Dr. Watson, what are some things that you learned through this pandemic?
Oh my gosh, what a great question. One of the things I learned through the pandemic is that you can't just, the pandemic showed things that we knew already existed. This concept of structural racism, systemic racism, because remember, we had 2 pandemics taking place. We had the COVID-19 pandemic taking place and systemic racism that reared its ugly head taking place. Those 2 things were happening at once. And they showed us the fact that we're not there yet. We made so much progress, but it reminded me that we're not there yet. And it told me about how much work that you all still have to do as young leaders. That I learned so much. I even learned about the fact that I learned to appreciate the smaller things. Actually, at the onset of the pandemic, my mother actually died from complications from lung cancer. So she died on March 9th, 2020. We had her funeral on March 14th, that Saturday. And then we went into lockdown as a country. I shouldn't say lockdown. We went into social distancing on that Sunday, March 15th. We had our funeral not knowing that everything was going to change, but it changed the day before we had our funeral. And I was one of the fortunate ones and one of the lucky ones that actually got to grieve a loved one through having a memorial service. But I've seen so many countless others. I've had family members that died from COVID-19, and I haven't been able to go to their funerals because they were out of state. I haven't been able to grieve the way I normally would grieve because of the pandemic. So I've also learned the importance of living in the moment and making sure that people know how you feel about them so tell people you love them, tell people you care about them, ask people that whatever I can do for you, let me do it now, because we don't know what tomorrow looks like. So I've really learned to be more present and live in the moment.
We do have a raised hand. Monica, if you want to go off mute, you can ask your question.
Yeah, so like within my family, I've seen some discrepancies about the COVID-19 vaccine, and some of it is because there are 3 different vaccines for it. So you mentioned that there was the Johnson vaccine, the Pfizer, and there was another one. So I kind of wanted to ask you, why are there 3 different vaccines, and kind of what are the pros and cons of each?
That's a great question. So the 3 different vaccines that are out that are FDA approved, I think I have a slide on that. Let me see. Yep. Okay. So right now there's 3 different vaccines out there. There's the Pfizer vaccine, there's the Moderna vaccine, there's the Janssen vaccine, which is called Johnson & Johnson. And so as you see here, there's there's 21 days for I'm sorry if I misspoke earlier. So there's 21 days between the first and second dose for the Pfizer vaccine. There's 28 days between the first and second dose of the Moderna vaccine, and there's no second dose required for the Janssen vaccine. So the other thing we need to make sure is that the boosters, that second shot is what we call a booster. That second shot is not interchangeable. If you start off with Pfizer, you cannot change to get Moderna or vice versa. If you start off with Moderna, you cannot change to get Pfizer, okay? And then no COVID vaccine within 14 days of another vaccine, which could make it less effective. And so some of the differences in terms of the science about the COVID vaccine, in terms of the science about the Pfizer vaccine, Moderna vaccine, the Johnson & Johnson, what the study showed us is that in terms of effectiveness, what does effectiveness mean, you all? Let's be very clear. When we talk about effectiveness, the purpose of the vaccine is not necessarily to prevent you from ever getting COVID-19 virus. We hope that is the case, but the full purpose of the vaccine is to prevent deaths from COVID-19. Okay, so let's make that clear. So both Pfizer and Moderna are fully effective at preventing deaths from COVID-19. Both are 100% effective. All of them are. The Pfizer, Moderna, and Johnson & Johnson, all are effective from preventing people from dying from COVID-19. But Pfizer and Moderna have about a 94% effectiveness in preventing you from getting COVID-19. That means that if you have 100 people in a room, 90, if they take the vaccine, 95 will be protected and will more than likely go on to not develop COVID-19 COVID virus, but 5 people may go on to develop it. So the difference is that each of them one is that they were developed by different drug companies. That's a big difference. And they were each developed with slightly different sciences. And as a result of those sciences, that's different. Each of them requires special delivery, special handling, and even the temperatures at which they're developed. But what I would tell you to tell your family member is that all 3 of the currently emergency use authorized vaccines are safe and ethical to take. And whichever one you get access to, that is the one I would recommend that you take. And have a conversation with your doctor if you have questions about whether or not you should take it.
Thank you.
Next, we have Terrace. You can unmute yourself.
Thank you. It's Therese. But, good morning and afternoon, everyone. And thank you for the presentation, Dr. Watson. I have 2 questions. So the first one is around how do you feel that Chicago or the state is doing overall with the vaccine distribution? And then the second one is what would be the best ways to kind of persuade or guide minority communities to taking the vaccine or looking to more information to make that decision for themselves? Because in my family, I know that my father or like close relatives are more stubborn or not too inclined to be taking the vaccine because of past or historical events. So yeah, that's the 2 questions. Okay,
so Teresa, I'm gonna ask you to help me out with the second question because they were, so go back to the first question and remind me what it was first.
How do you feel about Chicago or the entire state of Illinois?
How we're doing? Okay,
yeah,
got it.
With the vaccine, yeah.
I think we're doing okay. I would probably give us like a B+/ I don't think we're in the A- yet, but I don't think we're not in the A- or the A stage because I think it's just difficult to get an A right now in making sure that that we're doing what we should be doing. I applaud, this is not a political statement by any stretch of imagination, but I applaud both our governor and our mayor for really doing their best to try to make sure that they're getting the vaccine out to communities that don't have access to it. I think the Protect Chicago plan is a really amazing plan. The Protect Chicago plan, if you haven't heard about it, I would encourage you to go online, go to the Chicago Department of Public Health, which is cdph.gov, I believe, and look up Protect Chicago. Protect Chicago is a plan from the Chicago Department of Public Health that is prioritizing those high-risk zip codes that may not have access to the vaccine to ensure that the Chicago Department of Public Health is working with local federally qualified health centers, FQHCs, and community-based organizations to get the vaccine out to people who want it, but who may not have access to it. That you don't even have to be in the category of 1B if you're part of the Protect Chicago. Protect Chicago, all you have to do is live in one of those priority zip codes that's prioritized. You can be 18 or older and live in one of those priority zip codes, and you can get the vaccine through the Protect Chicago plan. So with efforts like that, I think that they're doing a good job. But I think that you can't address the disparities with COVID-19 without addressing the other disparities. You can't silo it out and just say, I'm going to talk about vaccine and not talk about diabetes, right? We have to continue to treat all the other ills in our society. So the same lack of healthy foods and healthy vegetables, the same community stress that can put someone's immune system in danger to put you at risk of diabetes or even cancer, it's the same thing that can put you at risk for COVID-19. So while I think we're doing a good job addressing COVID-19, we can't stop addressing systemic issues that lead to poor health outcomes. Because I believe if more people had better jobs, better places to live, that there'll be healthier people. It's not rocket science, right? When you live better, when you have better access to things, I live better now because I have more resources than I lived when I was in grad school. I eat better now than I ate when I was in grad school because I'm able to buy healthier foods. I have resources now that I did not have, even growing up. And the second piece of it, when you talk about family members that are still hesitant, first of all, acknowledge it for them. When you have these conversations, say, you know what you're dealing with is real. It's real. It happened, and it's still happening to us. But what's also happening is the fact that we're dying at unprecedented rates. And if this vaccine, for me, the conversation I had with my family was that even as a scientist, I still have questions. I'm not saying that everything is perfect. I still have questions, and I'm still wondering, okay, I'm still wondering, but my wondering did not prevent me from getting the vaccine. When I was approached to be able to get the vaccine, I took it because I said, I owe it to my community. I'm out here every day. I want to make sure that I'm protected and I'm doing what's right with social distancing and masking, so that if we are to be able to move on as a country, I want to be a part of that solution to allow us to move on. I also want to be a part of them being able to track and see how healthy people do with the vaccine. So when you get the vaccine, if you have any side effects, you can go through the CDC and report those side effects, right? So if I'm approached for a study about participating in a research study to track people who have not been impacted by COVID-19, who have had the vaccine, I'm going to sign up. And the reason I'm going to sign up because I want them to be able to track how people who look like me, who live where I live, how we do and how we respond to the virus. And I hope that answers your question.
Yes, it did. Thank you.
And
And
Alicia?
Alicia? Sorry, I apologize. I did not pronounce that right.
Great, thank you. And I agree with everyone. This has been really informative. And my question is, why are there 2 doses for some vaccines and 1 for some others?
That's a great question. So the second dose is what they call a booster. That booster shot, so that booster shot is where you get one shot and your immune system builds up its initial response to it. But that initial response makes you probably only we think about 70% effective. But that gives your immune system time to react and respond to it. That second shot is what we call a booster that allows your immune system to say, all right, I'm really gonna amount the memory I need to combat this virus now. And the way that the Johnson & Johnson was designed, it was designed where they said up front, it did not need a booster. And so you may, and I also want to encourage you all to not be discouraged or not be alarmed if next year or 2 years from now, we find out that, because we still don't know, you all. We don't know if the COVID-19 vaccine is going to be one of those vaccines where we have to get every year, every 2 years, or every 5 years, or like the tetanus shot every 10 years. We don't know if it's going to be like the flu vaccine where we have to get it annually every year. We don't know. So as the science evolves and we find out, I want to encourage you all as future scientists or just future, people who deal in evidence-based data to say that science is constantly evolving. We may know something tomorrow that we did not know today that may change a little bit of how we do it. So if we find out 2 years from now that you don't need a booster shot, I don't want you all to say, see, I told you, they didn't know what they were doing. No, that's science evolving. That's what we should do. Science should always be evolving.
Great, thank you.
Right. Thank you so much, Dr. Watson. And I feel like just to wrap up the conversation that we've been having, I wanted to ask Dr. Watson what you think the new normal would be, kind of moving forward, even if we see a future of a lot of people accepting the vaccine.
The new normal. I'm working with our church right now to think about what we're going to do for Easter, because this is going to be our second Easter not being able to come together in our church. And so our pastor has said that, he's like, we're not having service still. Our church has decided that we're still not moving to a place where we're comfortable having in service, because we have a lot of older members in our congregation and we don't want to have service yet. But he's going to be at the beach on the south side and for a sunrise service. I might meet him out there and stand 6 feet away. That's a new normal. I didn't expect Easter to look like me going but then I think about it and it's a sunrise, right? It's, would I love for Easter service to be inside our beautiful sanctuary? I would. But when I think about what Easter means for me, I can celebrate that anywhere as long as I'm being mindful of what it's about. So the new normal, I think, is going to be about us. We may not do things the way we've always done them, but we're going to create new ways of doing things. One of my used to be a mentee, now a colleague, James Stinson, he got married last year via Zoom. And when I went to the Zoom wedding, I was like, oh, this is going to be interesting. I can't tell you that. For some reason, that was one of the most beautiful weddings I've ever been to. They were able to evoke their love for each other through the screen. And I was like, am I getting misty at a Zoom wedding? And I found myself emotional I cry anyway, but I found myself emotional at a Zoom wedding because, again, you all, it wasn't about the screen. It wasn't about the fact that we couldn't be there. It was about the fact that we had all, and that aunt who would normally be at the wedding, you know, who would walk into the wedding late, she was on the Zoom screen and kept unmuting herself like, can y'all hear? Can anyone else hear? And I was like, wow, that family member that would normally disrupt the wedding has found their way to disrupt the Zoom. You gotta love it. So that's kind of the new normal, right? And I hope that we'll be able to celebrate James's, 1-year anniversary with a beautiful reception, because that was their plan to say, all right, we couldn't be together for a reception, so we're going to get together for a reception a year later. I hope that's the case. If we have to have on a mask, I know personally, I won't be going to any airports anytime soon without a mask. Even after this is over, I think I'm going to be masked up in the airport for a little while, just because I want to be extra safe during traveling. There's no evidence behind that. That's just my own thing. But I do look forward to traveling soon. I got my passport back out, and when they lift the ban to travel, I am going to take a trip. I am.
All right.
Okay,
Do I have any
sorry,
intel? There was one last question. I don't have intel. There is one of the vaccines, you can be 16 and older and take it. I don't have any intel right now. A friend of mine was looking to actually enroll, one of my colleagues was looking to enroll her kids in a study for the COVID-19 vaccine because they are under the age of 12. And so there are studies that are actively going, but I don't know when those studies will be approved to actually begin to vaccinate youth that are under the age of 16.
Okay, to be mindful of Dr. Watson's time, we are now 3 minutes over. Again, thank you all so much for coming, for participating, for all of your questions. And also thank you to Dr. Watson for taking time out of your Saturday to be here with us. I know, or Nana, I will turn it to you to wrap up.
Yes, and so again, thank you so much for participating in our event today. But then I was going to say, please be mindful and just be on the lookout that we'll be having future events. And so you would probably be added to a listserv. And so once you see that email from us, just know that it's one of our events that's going to be just like this. And so thank you again, once again, for attending.
Thank you all. Be kind to each other. Bye-bye.
Thank you all. Thank you, Dr. Watson. Bye.
Thank you. Bye.
Bye.